Okay, so good afternoon, friends. So today I'll be talking on this important topic, redesigning ICU. Um, so the topic is, the redesigning of ICU and our understanding of aerosolization in the within the ICU and within the hospital. So this is a very important topic. The reason is because there is a lot of spread of infection through airborne contamination, and we need to see as to what all engineering measures we can put in place to avoid this airborne spread of this COVID-19. And I believe after having read these two important articles, so this particular article, as you see, came from Indian Institute of Science from Bangalore. It came on 3rd May 2020. It's a good article. There was another article which came in Environment. So both these articles try to draw attention to a lot of engineering changes that needs to happen within hospital, within ICU to mitigate the spread of COVID virus. Because increasingly it is recognized more than the fomite transmission, airborne transmission seems to be prevailing in COVID, and increasingly it is being recognized that the healthcare professionals are at a much higher risk of contracting this infection on the line of duty. The reason being because of possible presence of increased presence of virus in the air within the organizations they would work, and greater is the risk of their exposure to this virus. To that effect, these two articles have deliberated. I think it's a good manuscript, so I would encourage people to read this whenever you have opportunity. So as you see, when you look at ventilation, so this is a typical sort of an ICU if you take it in a pictorial format. So you are in a conditioned space. So basically there is, when we talk about ventilation, whatever air is within a contained space has to go out, because this air which is prevailing is contaminated, and the new air, see, the outdoor fresh air has to enter into this. So our whole attempt should be to eliminate all the air which is contaminated outside, and this air should be ensured that there is no recirculation, because once this air from inside which has gone out, if it gets recirculated through the conditioned system or air conditioning system, then there would be recirculation of the contaminated air and the risk of infection would be there. So our whole emphasis has to be to mitigate that, and fresh air has to be facilitated. So whatever talk I'm deliberating, we are not experts. As doctors, we are not meant to have a great expertise or understanding these systems. And as you see through the narrative, you will see there are set of engineers who should work on these sort of engineering changes that needs to be incorporated. So it is being emphasized in this paper that the whole ventilation has to be restructured or reorganized to a point that you should have a lot of blowers and there should be unidirectional flow. So basically what that means is you should have sort of a fans which move the air in one direction, and all this need to exit in another way, and there should not be recirculation. So the whole problem of COVID prevailing in higher concentration within a conditioned space would be the recirculation of the contaminated air. I think that needs to be mitigated. And the whole emphasis in these two manuscripts is about unidirectional flow, so that there is flow of air which comes into a conditioned space and then it goes out in one direction, and there is a new outdoor air, we call it as a OA in the engineering parlance. Outside air needs to come in, and there should not be recirculation of the air. So that remains the gist of how that engineering or structural or functional changes has to be incorporated. So this manuscript very interestingly mentions about, even if the air gets recirculated, how the contamination of that recirculated air can be avoided. So they have put up this schematic diagram. So it's a very interesting. So suppose we are in a hospital where air is exiting from the exhaust vent. So what the author suggests is it can go into a hot water bath. The air that comes out of the expiratory ports or the ventilating ports could be sent into two sort of a water systems, one with a hot water bath where all the live virus which may be going out of this contaminated environment gets killed, and after this air could be recirculated into hot water bleach or with a detergent, so there will be further elimination of the whole viral contamination in the air. And even if this air gets recirculated, we know that the virus is eliminated. So this is a schematic representation which has come from Indian Institute of Science, and they believe this can be easily done. So in all the outlet uh, ventilation wherever the air is exiting, so it could be treated through this hot water or to this bleach solution, where you could decontaminate the whole air. And the authors do suggest 70-degree is a good temperature where the virus gets inactivated within 5 minutes. So if you treat this air into this water bath for about 5 minutes, so all the virus tend to get deactivated when the temperature is maintained at 70-degree. So currently, most hospitals, if at all anything they would be doing, so they would have kept the HEPA filters. So basically, the air that is exited out from the hospital system is made to be, is made to go through these HEPA filters with our understanding that all the bacteria and the viruses are eliminated. But the authors do subscribe that use of this HEPA filter may not be effective in eliminating this coronavirus because the diameter of it is extremely small. So HEPA filters can eliminate maybe bacteria, maybe a bigger particles, but coronavirus is only 0.08 to 0.16 micrometer. So the authors raised the suspicion whether these HEPA filters are good enough in eliminating the whole virus. And these HEPA filters also need certain treatment, and all the guidelines how we manage these HEPA filters come from a established guidelines from established organizations called ISHRA. ISHRA is International Society for Heating, Refrigeration, Air Conditioning Engineers. So this is an international society. Then there is an ASHRA. ASHRA is American Society of Heating, Refrigeration, Air Conditioning Engineers. So like how we have Indian Society of Critical Care Medicine or Physician Society, so there is these organizations which on time to time give you guidelines, and these guidelines have to be regimentally followed. And those guidelines do raise the suspicion whether HEPA filters are good enough in eliminating this virus, where it may fail so for such a small virus. I think that is something we need to. So if we are all in a comfort zone saying yes, we have a HEPA filter at the expiratory port, and whatever air is getting recirculated is decontaminated, maybe that may be a false, because it may not be effectively eliminating these viral particles is what the authors. Because as I said, I am not an expert in these in these engineering aspects, but this is what the manuscript highlights. And the manuscript also talks about any makeshift ICU, any makeshift ICU that one talks about. Like suppose now we have in Bangalore International Exhibition Center, which is converted into a COVID space. Or if a hospital is looking at converting a space into a COVID space, then the recommendation is open ventilation is the best way to eliminate the virus. So this is a pictorial representation where cross ventilation, where air comes through whatever inlet, and then it needs to go out into another outlet. So the unidirectional flow and exiting through a defined pathway is a good way of ventilation that they have proposed. So any place which is converted into makeshift, so some sort of a thought and deliberation has to be done as to the airflow, because it needs to have a unidirectional airflow, and there should not be recirculation of the airflow. And open ventilation is what is recommended, where you have open windows, open doors, where cross ventilation happens more effectively, and this is preferred over a closed space with the air conditioning. So this has been emphasized time and again in this manuscript. And what they suggest is to have blowers and exhaust. I showed you that other picture where you have blowers. The reason they suggest blowers is the blowers will ensure there is unidirectional flow. Suppose you keep all the fans on this side of the room, then you are ensuring that air that enters is going out in this exit pathway with the help of the blowers. So blowers and exhaust could be utilized to facilitate unidirectional airflow. And this particular manuscript from Indian Institute of Science does give some recommendations on toilets. So it is recommended that toilets have a touchless mode of functioning. Like you have a sensors which help you in so that there is no need to touch these taps or any toiletries. and even there is a suggestion made that there should be a warm water that should be supplied in all the toilets which are dealing with COVID areas, because the heat itself may tend to deactivate the virus. And even there is a suggestion there should be a hot water with soap dilution to be, to be made available, so that there is effective cleansing and deactivation of this virus. So right now, even in our hospital, we have more of cold water. So there is a suggestion towards having hot water as a regular supply, along with a detergent mixed with it, so that there is a regular decontamination happening with the water usage. And this manuscript does recommend that the tissues have to be dissuaded, and so the hand dryers may be more desirable, is what it is mentioned. And obviously we cannot underemphasize on effective surface cleaning, because the COVID virus can be present on any of the surfaces, and they act as fomites, and any surface within ICU can be a potential source of COVID being present. So this is about the Indian Institute of Science manuscript. I think this is a very good article which came in environment. I think this is an article I would suggest all trainees to go through. So how can airborne transmission of COVID indoors be minimized? So this is a good scientific paper which deliberates on the whole literature that is available on the viral load that is present in various areas. So this particular manuscript looks at 7 studies which has looked at air sampling to see if coronavirus is present in the air, because that is the whole debate. Because initially our understanding, even when I gave this some few presentations in say March, I said that the main risk of COVID is from the fomites, because we thought it is present in the droplets and it is a bigger virus, it is sits on the fomites. And there was an underemphasis when it started in March on the airborne transmission. We were more worried about taking care of hand sanitization and things like that. So now this particular paper looks at the air sampling, which was done in 7 studies, and the 4 studies identified presence of COVID in the air. So in the air, wherever you have corona, so there is presence of COVID, which was identified by PCR. And there were 2 studies which have looked at very small numbers present in the air. So 4 studies looked at significant presence of COVID, which was identified by PCR. There were 2 studies which looked at very small number of virals and viral particles present in the air. And there was 1 study which showed no positive air sample. So this is the current evidence. So where 4 studies at least have very convincingly said that there is presence of virus within the air. So the Singaporean study, they looked at the air sampling and they identified that the viruses present have a size anywhere between 1 to 4 micrometer to greater than 4 micrometer. So that is the size of viruses that is present in the air, and the concentration of the viruses in the air as per the Singapore study was 1.8 to 3.4 copies per liter. So which means there is a significant number of these viruses of variable sizes present within the air. And this was a US study which came from, I think, Nebraska. So where they have said 63% of the air samples which they took from the COVID area were positive, and the concentration of virus was 2.9 copies per liter. So that was from the US study. And I think this is a very good study where they have looked at what is the concentration of virus in relation to the distance from the patient. So they have looked at, when they looked at air samples close to the patient, they saw the copies, the number of copies was 4.1 copies per liter, which is more. So if you take the air closer to the patient, the number of copies of virus is much more. So the more proximate you are to the patient, the higher is the concentration of virus in the air. So if you are present at more than 1.8 meters away from the patient, or maybe 4 feet away from the patient, then the copies come down. The number of viruses present in the air comes down to 2.5 copies per liter. So the more closer you go to the patient, air has higher concentration of viral copies. So the further you come out, the concentration of virus in the air comes down. And they looked at presence of virus in the samplers. Samplers means who are doing sampling for the patient, who are doing testing for the patient. They found they had 19 copies per liter deposited on them, which means if you are in contact with the patient and you are doing some procedure, so the number of viral copies were 19 copies per liter. And this is most interesting for ICU patients. When someone is on a nasal cannula or an oxygen device and you are near the patient, the concentration of virus is up to 48 copies per liter. So, which means to say, ICU personnel are at a highest risk because the environment or the air is having a very high concentration of viruses. Because as you see, there are nasal cannula itself, they have 48 copies per liter in the air. So in our ICU where we would have patients on HFNC or where we have patients on NIV, so I think the concentration of viruses in the air would be very high. So that is something I want all intensivists to bear in mind. So we are in an extremely high risk environment where the whole air present around us is having a very high concentration of viruses as compared to non-ICU setting, or you are farther away from the patient. So as you go farther away, the copies come down. So the concentration is very high when you are in touch with the patient, and the concentration is even more higher when they are on oxygen devices. So that is something I want every intensivist. So you are in a high risk area when you are dealing with a patient, COVID patient in ICU, especially who are on these NIV oxygen devices. So, and they have looked at, this was a Chinese study which has looked at the presence of COVID in toilets. Because initially, when I gave a talk in March, I said toilets also are at a high risk of contamination because virus gets threaded in the stools. So, they have looked at the toilet, the toilet concentration is 0.02 copies per liter, which is very less. See, these studies, what is showing is something remarkably new. Our understanding has changed, where we said initially that the surface contamination is what we should be worried. Now we are telling that the concentration of virus in air is much more than what you see in toilets. Because in air, even otherwise, you had 4.1 copies per liter if you were closer to the patient. And they have looked at PPE removal because in our unit, three of our doctors got affected. And when we tried to dissect out where these doctors could have been affected, so there was suggestion from our doctor group that probably the area where PPE was removed, doffing area, was at a highest risk because that is where the whole PPE. Because this Chinese study looked at it, the PPE removals place, they looked at the viral concentration in the air and it was 0.02 to 0.04 copies per liter. So it was very less in the doffing area, at least if you have to subscribe to this Chinese study. And this was another Chinese study, Liu et al., where they looked at droplet deposition. So the droplet deposition and the number of copies. So they looked at 3 meters from the patient, and they saw the viral concentration was 31 copies per meter squared per hour if you are 3 meters away from the patient, and if you are 2 meters, if you are closer to the patient, the number of copies, viral concentration within the droplets increases to 313 copies per meter squared per hour. So all these studies emphasize the more closer you are to the patient, the much higher is the concentration of viruses within the air, and much higher is the concentration of viruses in the droplets that get deposited close to the patient. And if you are dealing with a patient, typically when you go inside a COVID area in ICU, in a patient who is on oxygen devices, I think there's much higher concentration of these viruses in the air. So now the suggestion from this manuscript is, so what can we do to reduce this concentration of viruses? So this is something I believe still there has not been much of efforts that has gone in to adopt to these modalities to minimize this concentration of viruses. So one suggestion is engineering controls have to be made to reduce the potential airborne transmission. So the authors do talk about air purifiers that needs to be put in place in all these high concentration viral load sort of spaces. And there are a lot of air purifiers that are available, and authors do recommend that some deliberation has to be done in adopting placing these air purifiers. And authors do recommend the engineering, structural or functional changes have to be done. So that obviously is not our area of expertise. So what authors suggest is the amount of air coming in should be ensured that all this air from the conditioned space is eliminated, it goes out, and the new air that comes in should be significantly more than the air that is going out. So your inflow of outdoor air should be more than the outflow air. So the inflow air should be more than the outflow contaminated air. So that's what is pictorially depicted. And if this particular inflow not exceeding the contaminated outflow will lead to increase in the concentration of viruses in the environment. So to this effect, the authors re-emphasize constantly about changing, re-engineering certain functional abilities within the space to make sure that the inflow of outdoor air exceeds that of outflow of contaminated air. So this is what the authors constantly re-emphasize. And WHO recommendations is 160 liters of air circulation per second per patient has to happen, which means there should be so much of recirculation of the outdoor air should be brought in, and the indoor air has to be eliminated, because all this indoor air should not be recirculated is what is resonated at multiple instances in this manuscript. Okay. And it is also mentioned in this manuscript that the virus, once it comes into the air, it remains stable in the air for about 1 hour. After that, it can become unstable. So it has a half-life of around 1 hour. So where it remains active, and after that, slowly it may become inactivated. Okay, so again, the second one, the authors emphasizes ventilation should be recognized as a means to reduce airborne transmission. And generally, all the closed spaces that we work in typical hospitals where air conditioning, we use something called HVAC systems. HVAC is heating, ventilating, and air conditioning system. So any of the hospitals with a conditioned air adopt these HVAC systems, heating, ventilation, air conditioning systems. And all these systems, HVAC systems, are complex, and they have a set default mechanisms, set standard operating parameters on which they work. So now the authors re-emphasize that these set operating parameters that is set as a default may not be suitable for COVID, and these have to be tweaked and changed. So for that you need experts. So we are not experts, because these HVAC systems, why it is complex is they look into the temperature of the air, they look into the relative humidity of the air, and they look into airflow distribution and direction. So these are all set as a normal default in a normal situation. But now, considering we are in a pandemic situation where we have understood the dynamics of this airborne transmission of coronavirus, this whole HVAC system, the way it is functioning, has to be tweaked, has to be changed. And that, if it is not done by experts, which we confess we are not experts in this, so the structural engineers have to work on these HVAC systems to make sure that that inflow air exceeds that of a outdoor contaminated air exit, and redistribution of this air has to be mitigated. Unless we do this, so we would put in our healthcare people at a higher risk of getting exposed to higher concentration of virus with the present. So to that effect, the authors mentioned there are established organizations and their expertise have to be sought, like ASHRAE, American Society of Heating, Refrigeration, and there is a Japanese organization called Shashe and Rehwa. So there are organizations, there are timely guidelines. So I really wonder, and I suspect if any of these expertise is being adopted in any of these hospitals in our country, so there is a serious need for structural engineers to work on this, because this would be the area one should work to minimize the exposure of this virus to the healthcare community. And again, there are certain standards, so which are called as CEN and EN standards, where they talk about the number of air exchangers, where the air exchangers may be variable in these HVAC systems, where you are in from 2 to 50 air exchanges per hour. But we do not know what sort of air exchanges we could each hospital would be having. So this is something where structural engineers should put in their mind and their know-how to see how this whole air exchange can be more effectively managed. And see, again, the authors re-emphasize on avoiding air recirculation. So even the authors suggest that ASHRAE, again, that organization has come up with a guideline that 52.2 filters have to be placed. So I'm showing the pictures which you could possibly see. So there should be filters placed in the inlet hose and even in the outlet hose, so that there is effective decontamination of the air that is circulated. And there is an emphasis on outdoor air supply, which has to be significantly increased. So this is resonated time and again in the manuscript. And this aspect I want to re-emphasize to all the listeners. The authors do mention about utilizing ultraviolet lamp to sanitize the air and the contaminated air. So this is something which I urge the listeners to pay attention to and to adopt in their practice, because ultraviolet lamp, so there are ultraviolet light has A, B, C. The ultraviolet C component, which is now available, is known to eliminate coronavirus 1 and Middle Eastern respiratory. So our assumption is it is effective against SARS 2 as well. And ultraviolet C, basically it emanates the C rays. It is shown to inactivate SARS-CoV-1 and Middle Eastern respiratory virus COVID. So we know that SARS-CoV-1 and MERS-CoV-1 were similar to SARS-CoV-2, and MERS was more lethal than COVID. So if UVC is effective against that, it is normal for us to assume that this would be effective against SARS-CoV-2. So the authors do reiterate on adopting these ultraviolet C light or ultraviolet C lamps within the ICU to eliminate to eliminate the contamination of air by these viruses. And it is shown that it reduces the viral load by 6 log reduction of the virus within 5 minutes by using these ultraviolet lamps. So this is not something new. A lot of institutes have already started adopting this. So I'm showing this picture, which is being adopted in one of the medical college hospitals in Bangalore, where they have adopted these chambers, ultraviolet C chambers, to decontaminate or sanitize the whole PPEs that people would be wearing. And I think this is one what authors have been suggesting. So if you talk about we call it as ultraviolet used against the virus, they call it as GUV, germicidal ultraviolet lamps. And authors do suggest placing this germicidal ultraviolet lamps on the ceiling or on the roof, as I show in the picture. The reason is, once there is a airborne contamination of this with these viruses, the air has to be decontaminated on the ceilings or the roof, because that is where the air tends to circulate, and even the recirculated air enters from the ceilings. So authors have put it pictorially, saying that germicidal ultraviolet has to be kept in the roof end for effective elimination of these viruses. And it is shown that placing this ultraviolet ray reduces the infection rate, which is equal to twice the ventilation rate, which means to say the whole re-engineering of this air circulation, where I said you would increase the inflow rate, which is more than the outflow rate, easily that could be adopted even without that, by just having this ultraviolet light. It is shown to be as effective as that change. So along with that, if you have ultraviolet light, it is effective in reducing the air contamination by this virus. So I'll just show you this video which has been incorporated in one of the medical college. So where you would see this gentleman going into this ultraviolet chamber and getting his whole PPE decontaminated. And this has been set up as a experimental setup by, I think, HAL, and this has been shown to be very effective. So the person with PPE goes in only for a few seconds and comes out, and the whole PPE is decontaminated, so that that PPE will not cause further contamination of other areas where he goes to. Okay, so this is the picture of the UVC sterilizer, which is being incorporated in one of the medical college hospital in Bangalore, and they're using it. So we need to come out with such innovative ideas to protect our healthcare, to have these chambers or to have these UV lights placed everywhere, so that whatever air that is recirculated, we absolutely know for sure that the whole engineering mechanisms may not be foolproof, and there may be recirculation of air, and there may not be unidirectional flow of air, and none of us who are listening to this would be sure whether our inflow air is more than the outflow air or outflow contaminated air. So given all these limitations, because we know for sure there is no huge organizations who are putting in effort in this aspect about making sure that outflows are happening properly, and we are not sure what sort of filters, because whether ashtray specified filters are present in the inflow and outflow of the air circulation units, we do not know. So having limitations with all this, the only thing as doctor community we can subscribe to is placing these chambers or ultraviolet light to make sure that our environmental contamination with these viruses can be significantly reduced. Otherwise, more and more healthcare personnel may be at a much higher risk of getting affected with this COVID. So this is a beautiful diagram which authors have put up in this manuscript. As you see, open ventilation, this is sort of a summary slide. Open ventilation to be encouraged, and inflow air should be more than outflow air, and unidirectional airflow is what needs to be encouraged by keeping the blowers. And see, the authors very nicely have depicted how the recirculation of air to be avoided. Even if it recirculates, you will see there is a UV lamp here. See, they have kept a UV lamp on the roof. So even the air recirculates, it comes here, and the UV light will deactivate the viruses present within the air. So it's a very beautiful diagram. I think this diagram pretty much summarizes whatever I've said. So basically, open ventilation is what is recommended for a makeshift ICU, and the outflow air, the inflow air should be more than outflow air, unidirectional flow to happen, and recirculation of air to be avoided. Even if whatever minimal recirculation may happen, it could be decontaminated or sanitized by placing ultraviolet light. Or if you want to subscribe to the Indian Institute of Science, so any air that goes out should go through the hot water bath or to the soap solution. And you should adopt the ashtray criteria by you should have a filters placed both in the inflow and the outflow of recirculating chambers to make sure that much of the virus load is minimized. And and it is also suggested, the authors also say this UV lamp can be placed uh, within the ducts where the air circulation happens, so that all the viruses that flows through the inflow and outflow ducts get decontaminated. Even that is suggested by the authors. So this is a beautiful figure which again gives us insight as to what we are paying attention to and what we have not paid attention to, which possibly we should. See, here they say elimination, to physically remove the pathogen should be the top priority, and I do not know whether we are putting much efforts in this direction to eliminate the virus from the environment. I think there we need more work, we need more intellectuals putting their thought. And the second most important is engineering control. So whatever I spoke about it, like blowers and having filters in inflow outflow unidirectional, placing ultraviolet, these engineering controls is to make sure that you minimize the viral load within the environment. This is the second important aspect in curtailing this pandemic. The third is administrative, to instruct people what to do. So what we are adopting currently as doctor community is third one. So we are instructing doctors to wear PPE, mask, and staying away from the patient, social distancing. The last one is PPE. So the whole doctor community is struck to the last one, which is using mask, gowns, gloves, because basically we have virus all around us and we are trying to protect ourselves from that virus. And the second thing what we are paying attention is to maintain distance from the patient so that we get less affected. But as you see, those are two least effective methods that we have embraced or adopted. Rather, the most effective, the authors say, is elimination of the virus and decontamination of the air where the virus is present by restructuring the whole functional and structural aspects of the engineering processes. I think this is where I believe more efforts, more thoughts, more deliberation has to be done. And the reason why we are deliberating so late is because we are not experts in that area. So I sincerely urge everyone who is listening to this to talk to your own structural engineers and put more mind into this, so that, I mean, we may not be able to give them much advice, but at least let them put these efforts in trying to see if any of these measures, for me as a doctor, as an intensivist, the simplest thing that I could adopt is placing UV lights everywhere, so that whatever virus load can be minimized within my ICU environment. I think we can significantly protect our healthcare personnel, and we can even significantly protect our patients by reducing the viral load in a much better way. So that would be my thoughts. So thank you very much. So again, this quote, I end with this quote which possibly applies to corona. the 40% rule. When your mind is telling you that you are done, that you are exhausted, that you can't possibly go any further, you are only actually 40% done. So possibly right now this sort of a ending is very apt. So whatever we are doing now is possibly 40%. We have to still work 60% in adopting these newer technologies and this whole putting our mind into this engineering process to minimize the viral load in the environment. So thank you very much. So if you wish to rehear to this lecture, you can visit my website www.drpradeep.Rangappa to rehear, and you can contact me for any doubts or any clarity on this. Thank you.